closely. She was initially very symptomatic, very minimally symptomatic. And so we were monitoring her, and this was a picture that was taken a couple months after my initial visit with her. She started noticing some worsening of her vision, and she was very keen to try pneumatic vitrolisis to see if she can avoid surgery. And she had, in this case, an excellent result. We positioned face down after doing a standard pneumatic retinopexy, and over the course of the next 3 weeks, the vitreomacular traction released with subsequent kind of progressive closure of that outer macular hole. So I would say, depending on the extent of the OCT findings, is how I kind of discuss with the patient what could potentially be some of their options.
And Robert, there's a question here from Dr. Mukhtari about what amount of visual loss makes you go towards a vitrectomy for VMT. What's your criteria?
I don't have a strict criteria in terms of the vision, right? I have a detailed discussion with patients regarding these options in terms of the success rate of each option as well, and some of the complications associated with both pneumatic vitrolisis and vitrectomy surgery. So I don't necessarily have a clear cutoff, but if I have a patient who's very motivated to both position and avoid surgery, then pneumatic vitrolisis, I think, becomes an excellent option if the rest of the features are favorable as well.
Great. So we're going to move on now from macular holes to another common problem that we see often, and that's the macular pucker cases that we see. And again, these can vary, where you have very minimal disruption of the foveal contour with asymptomatic epiretinal membranes, to other cases where there's significant disruption of the fovea, and these patients can be quite symptomatic, sometimes from a distortion perspective, despite having reasonable visual acuity. And there's a lot of subjectivity into when we decide to proceed with surgery or not. David, I know that you've developed a classification system for macular puckers. Do you want to just briefly mention that and how you use it in clinical practice?
Yeah, I should acknowledge Andrea Govetto, who was a fellow with us at Stein when he developed the system, and I was privileged to collaborate with him. He's now in the UK, but originally from Italy, and the system is actually, I think, excellent. It doesn't include some of the associated complications that can develop, such as the cystoid degeneration, that can be associated with ERMs. But in the absence of fluid, you can often see essentially 4 situations. And these 2 OCTB scans really do a good job of capturing the changes. So when there's a normal foveal depression, we refer to that as grade 1. When you lose the foveal depression, that would be grade 2. And in the case in the B scan above, I would say that's a grade 1 to 2 ERM. And those are the more favorable cases. If you do cross-sectional correlation with visual acuity, you'll see the 1s and 2s do well. The 3s and 4s are when you run into trouble, the baseline vision is worse, and the post-op vision after peel is worse. In this particular case, in the bottom, you can see an ectopic foveal inner retinal layer, where basically you have the presence of the internuclear layer and the inner plexiform layer across the fovea. And that would indicate a grade 3 level of ERM. When there's disorganization, you can't make out the different layers of the ERM. That's the worst case scenario, and those are grade 4. So I think in the bottom panel, the bottom B scan, that would be a grade 3 ERM. I have to give a recognition and a shout out to Dave Chow from your neck of the woods, who published a nice paper showing that these grade 3 and 4 ERMs do much worse after peel, after ERM peel. So ideally, you'd like to operate on these patients, especially before they get to the grade 4 level of ERM. But I think it's not a black and white issue, and you've got to have a conversation with the patient and gauge their level of disability.
Yeah, I definitely agree. These are the types of patients you never want to kind of push into surgery, or it really has to come from the patient, because there's a lot of times where it can look awful on the OCT, and you do the surgery and the patient feels that it's worse despite an improved OCT appearance. So I think that that's a good advice, David. So we've talked about full thickness macular holes. Another thing we commonly see is these lamellar holes. And there's a wise retinal surgeon in Toronto who once said that the only way to convert a lamellar hole to a full thickness macular hole is by doing surgery on it. So I know that some have described surgery for this type of condition. Robert, do you ever, what's your approach to lamellar holes when you see patients with this pathology?
So yes, I'm always very not hesitant, but careful in these types of situations, even more so than in the epiretinal membranes. I think in these cases, really, the symptoms of the patients is really what kind of guides my hand in terms of whether I want to intervene or not. How much distortion they have, or how much functional visual impairment they have, and also I don't find these surgeries very satisfying in terms of success rate, right? These are difficult patients to manage. Surgery, I think the outcomes are not as predictable as we would like as to who's going to really have a great visual outcome and versus who isn't. And so I always counsel my patients. Well, we have these are probably the longer discussions I have with my patients in terms of surgery, as to really kind of trying to isolate what is bothering them within their vision, and if it's something that we can address with surgery or if it's something else.
And the lamellar hole, we want to differentiate it from the pseudo hole appearance, which is what you can have the appearance of a macular hole when you have a patient with a macular pucker, as shown in this type of case. But yeah, I agree with your general comments. I would say I never operate on them, almost never. I mean, you never say never, but it's very, very rare that I would do surgery on a case like that. I'm going to turn it over to David now. David has two very interesting medical retina cases, and I'm going to just advance the slides for you, David, if you want to discuss these cases.
All right, thank you very much, Rajiv. I've enjoyed the discussion and the images so far. So these are our two medical retina cases. Both have been actually published because of some novel findings. In this particular case, we see these very small hyperfluorescent dots. And if you just look at this fundus autofluorescence, the diagnosis is not entirely clear. The spots that you actually see with multiple evanescent white dot syndromes look very much different. And here you can see the higher magnification, the 50-degree fundus autofluorescence that show these very small, discrete hyperfluorescent dots. We actually published a paper recently of all the entities that can masquerade as MUDs, and those include PIC, or punctate intrachoroidopathy, primary vitreoretinal lymphoma, retinal vasculitis, and even paraneoplastic syndromes like CAR, or autoimmune syndromes like Azure. But in this case, these were discrete dots related to MUDs. And if you actually look at the timeline of these dots, it's very interesting. Here you can see a more classic appearance of this unilateral hyperautofluorescence. And that background hyperautofluorescence you're seeing relates to the spots, the larger spots that you see at the level of the ellipsoid. But if you look really, really close, you can see little dots above this larger background of spots. And if you follow the autofluorescence, you can keep going, Rajiv, you begin to see the dots come into focus as the background autofluorescence of the spots begin to disappear. And this, if you keep going forward, this is now 6 weeks ahead of the baseline. All the spots are gone, and all you see are the dots that remain in this young female patient. So what do these represent on OCT? And here you can see the patient was a healthy young female, as you would expect for MUDs. And here's what's interesting. We've also published this. If you do en face OCT, you can actually see the discrete dots overlying the reflective spots. And so if you segment through the dots, they actually represent extensions into the outer nuclear layer from the areas of ellipsoid loss. So the dots are actually hyperreflective, and they are overlying a background of hyporeflective areas where the ellipsoid is gone, and those represent the spots. And you can show some more examples of that. And here you can see, this is again in the timeline, the background hyporeflective spots are beginning to disappear, and you can still see these hyperreflective dots that are the extensions from that bed of ellipsoid loss. And if you go forward again, you can again see this timeline. So look at the background spots, they're hyporeflective, they represent ellipsoid loss, and the overlying dots are the areas where you see these hyperreflective extensions into the outer nuclear layer.
So David, is this just material damaged cells that are congregating, or what exactly do you think it is?
We don't know exactly, Rajiv. That's an excellent thought. We refer to MUDES as a photoreceptoritis, a primary inflammatory disease of the photoreceptors that results in ellipsoid loss, and maybe aggregation of photoreceptor debris or some type of inflammatory material that is extending from that bed of ellipsoid loss. So absolutely. What's interesting is if you do OCTA of the MUDES, and it's still a controversial issue, we don't see any interchoroidal changes. The choroid seems to be intact. So we think this is a primary viral retinitis, viral photoreceptoritis, and then you can see these ellipsoid changes very nicely that typically resolve. And here you can see again the ellipsoid change, and then a dot that is extending into the outer nuclear layer. The ellipsoid begins to resolve, and you can still see the dot in the bottom panel. This is at baseline 2 weeks and 6 weeks. You can see the timeline resolution. Yeah, exactly right. Thank you, Rajiv. And so it's really cool. Those dots were actually described many years back by Yanuzzi when they did ICGA. And we were able to actually identify them now with autofluorescence and OCT, and they probably do represent some kind of inflammatory debris or inflammatory material extending from the area of ellipsoid loss, which are the spots. And you often get that central flocculent area in MUDES, yes, and it often extends up right in the center of the fovea. And this is another area that we're very interested in. We believe that there's a seam or plane through the center of the fovea. And you can often see hyperreflective lines or hyperreflective changes right through the center, which may represent this plane. And not only in inflammatory diseases, you can see blood insinuate through that central plane. And often in vitreomacular traction syndromes, before macular holes, you'll see a white hyperreflective line. But in this case, it's a much thicker area, and it again represents a more central representation of that inflammatory material, or those dots that we saw at more eccentric. And as we all know with MUDES, after a few weeks, there's reconstitution of all the outer retinal bands, as you can see in the follow-up here. And this is just again showing the en face changes, which you can just go forward with. And the co-localization with the fundus autofluorescence. So those tiny discrete hyperautofluorescent dots, they correspond to the hyperreflective lesions in the outer nuclear layer, and the hyperautofluorescent background corresponds to hyporeflective ellipsoid loss. And there you can see the timeline again, co-localizing the autofluorescence with the en face OCT and the cross-sectional OCT. This is courtesy of Jackson Scharf, one of our fellows who's actually a medical student who wrote this up for retinal cases and brief reports. I went through that fast.
Yeah.
There may be some questions. Have a minute or two. I'm happy to discuss
So David, there's a question. Do you do electrophysiological examination on these patients? And
no, I mean, unless it's a masquerade syndrome, and I would encourage anyone who's interested to look up that paper. It is a interesting paper that shows that when you see by actually one of the fellows at Baskin, his name is Russell, is the first author. When you see atypical changes with regard to the diagnosis of mute, so let's say an older patient or bilateral presentation or persistent vision loss, then you have to start thinking about some of these masquerade syndromes, such as even a Azure or a paraneoplastic retinopathy. And it's in these situations that, depending on what the concern is, I might get a full field ERG.
Great. So we're going to move into your second case here, David, of a 65-year-old woman with decreased vision for 5 days and
Okay.
has a history of Horner syndrome and hypertension, pulmonary emphysema. These are the images here.
Yeah, so this is actually another of the white dot syndromes, but here you can see that there's clearly choroidal involvement. And in fact, choroidal involvement that's driving the disease. And OCT angiography is a critical modality to identify this choroidal ischemia. And this is actually a TopCon OCTA. I have several instruments that I like to use for OCTA, and this is one of them. And you can actually see the patient initially presented with choroidal ischemia, interchoroidal or choriocapillaris ischemia on the left panel. And 3 weeks later, you can see dramatic progression of that interchoroidal ischemia, actually in both eyes. And if you go to the left eye, you'll see again dramatic progression of that interchoroidal ischemia. So there are various entities that can cause interchoroidal ischemia, and the one that's most common, of course, is AMPI. And this is a case of AMPI, although if this would continue to show progression over 3 months, it would then move into a more ominous category, which would be relentless placoid. And any persistent areas of ischemia after 3 months would be then in the category of persistent placoid chorioretinitis. But these lesions did eventually resolve, and so this patient, in fact, did have AMPI. And if you move on, you can see.
Sorry, just one question,
Yeah,
David. When you see this extent of choroidal ischemia, does that change your decision making in terms of for AMPI performing an MRI to rule out cerebral vasculitis or other investigations?
Yeah, that's an excellent question, Rajiv. You always have to be concerned about a meningitis when you have placoid disease. No one's ever correlated it with the OCTA or the ICGA findings. So by and large, I just make sure I discuss it with the patient. If they have any headache, meningismus, or any signs of a meningitis, then I'll refer them to rheumatology or infectious disease to consider an MRI or even an LP. But by and large, that's very rare. I don't know, Robert, do you have some things to add, comments about how you manage patients with AMPI and placoid disease?
I would agree that I think central nervous imaging is important to rule out these areas of vasculitis. I had a question actually regarding your use of ICG in these cases with such detailed images in the OCTA. Does ICG still have the same place in your management, or do you tend to follow more the OCTA in these cases?
That's right. No, I tend to follow the more the OCTA, and I think in this case you could make an argument that the the ICGA probably wasn't necessary. But one benefit of the ICGA, as you can see in this particular case, is you have wide field capability, and that's kind of still an evolution with OCTA. We can do 12 by 12 millimeter OCTAs, but you can get out 200 degrees, and you can see that the extent of ischemia in this case is much more than you can appreciate. Not just by posterior pole exam. Sometimes clinically you don't appreciate this degree of peripheral ischemia, and it just shows you that the choroidal findings are really primary in this disease, because you may not see these peripheral retinal areas of ischemia that you appreciate so nicely with the ICGA. But your point is well taken. I think as OCTA develops more and more wide field capability, and even without, I think you could make the argument that dye-based angiography, including fluorescein and ICGA, are probably not necessary. But this patient was happy to go forward, and we were able to identify a more severe peripheral involvement in this particular case. We actually started him on steroids because he had severe vision loss after he returned, so we were concerned about him.
So there's a number of questions here, guys. I'll just ask you. So, you know, there's consideration of whether giant cell arteritis can look like this, whether Azor can look like this, and how you would treat this. I believe steroids is usually for severe cases where there's significant vision loss. You know, we use steroids, but do you guys want to comment on GCA and Azor in the differential diagnosis?
Well, GCA, excellent, astute comment. We've actually published on choroidal ischemia with GCA, and usually you'll see peripheral areas of triangular infarcts, what we refer to as Amalric infarcts. So the pattern of choroidal ischemia that you're seeing here is, I would say, atypical for GCA. I've seen several cases, and often you'll see these triangular areas extending from the temporal macula to the periphery in the distribution of the long ciliary arteries. So it's more a larger ciliary infarction as opposed to ampy and placoid diseases, which are more interchoroid at the level of the choriocapillaris. So it's a different level of choroidal infarction.
Great. And David, I've just put up the OCT here now showing these hyperreflective lesion.
Yeah, these are really cool. That top panel shows you the characteristic outer retinal changes that I think are driven by the choroidal ischemia. So you see these hyperreflective lesions that kind of extend into Henle's layer. And Henle's layer acts like a conduit or track. So you can see exudates radiating in it. We refer to that as a macular star, like in hypertension, exactly. And, or you can see heme layer. We just published a paper of Henle layer hemorrhage in venous disorders. So inflammatory lesions can also track through Henle's layer, and you can see that beautifully in the right eye. We put the patient on steroids, and you can see reconstitution of the outer retinal bands and resolution of the outer retinal changes. But he didn't have, this is not like mutes where you see recovery of complete vision. I still see him, and he does have some persistent vision loss. And here the colors just showing the interchoroidal plaques in the right and left eye. Thank you, Rajiv. Yeah, exactly. They're actually, yeah, you can see them better here on the optos, the whitish areas in the macula, so central and nasal. And this was his resolution, showing the pigment changes that often are the legacy of these placoid lesions. And that's it. I hope
Rajiv, can you just go back to the last follow-up? Is there kind of do you see eventual kind of attenuation or restructuring or reperfusion of these choroidal defects over time?
So yeah, these are the follow-up OCTAs of the inner choroid, and you can see that the severity of hypoperfusion has improved dramatically. But there seem to be some residual areas where there still is attenuated inner choroid. And sometimes in the areas of these placoid lesions where you initially have flow deficit, you end up seeing projection and evidence of just atrophy of the RPE and attenuation of the choriocapillaris. So there is often a legacy of change that you will see, Robert. Exactly right.
Great. Well, that was an excellent discussion on the white dot syndrome. So I'm going to transition now into another case here. This is a patient, a pediatric patient who was referred by the optometrist for this abnormality on the OCT. And here you see some cystic or schisis-like changes nasally. The temporal side looks relatively preserved, and OCT through the optic nerve shows a potential deficit there. And if we look at some additional pictures, we can see that there is a optic pit-like lesion with multi-layer schisis present. Robert, I'm going to turn it over to a case that you provided here of a patient who had optic pit maculopathy with subretinal fluid and intraretinal fluid. And if you could just go over what you did in this case.
Yes, thanks, Rajiv. Yeah, so this is a 13-year-old boy that was referred by his optometrist to our retina clinic, and he was basically just seen on a screening exam. He hadn't really noticed any changes in his vision at all, and he basically came in with a vision of around count fingers in that eye, and as we can tell here, so he has large cystic outer and inner retinal changes, subretinal fluid, quite significant subfoveal atrophy as well. And it's maybe a bit difficult to see, but he does have this kind of infratemporal darkening around the edge of the optic nerve that correspond clinically to an optic pit. So, in discussion with his parents, they were initially hesitant to proceed with surgery, just given his, the overall prognosis. We've discussed kind of that there's surgeries for this can sometimes be quite frustrating, and multiple surgeries is not uncommon. And so I was monitoring him quite closely. And over the course of around 1 or 2 months, he started maybe noticing himself as well a bit of a larger central scotoma. So we didn't end up proceeding with surgery. In this case specifically, what we did is so it's a vitrectomy, detaching the posterior hyalid, which, as we can expect, is quite adherent at that age. And I did an ILM flap that I then proceeded to tuck into the optic nerve and into the optic pit, followed with kind of the seal glue. So the picture on the right is the picture from earlier this week. I saw him at a 1 month post-op, so he's already had some improvement in these outer and inner retinal schitic changes, and some decrease as well in the subretinal fluid. And so hopefully this will kind of continue to improve over time. I did do an OCT through the nerve. Unfortunately, I did not see the ILM flap over the nerve, so I'm not sure if it stayed in place or it kind of got displaced in the post-operative period. But we'll continue to kind of monitor him and see from there. What's been kind of your experience, Rajiv, in these types of difficult cases?
Yeah, I've seen a number of these, and initially, like you're alluding to, you just want to observe and see what the situation is. A lot of times, the fluid itself can spontaneously reabsorb, either by vitreous occluding the defect or other process, and so. First of all, I just wait and see. I often want to document a definite deterioration in vision before I proceed to surgery. As you mentioned, there's about a 50% recurrence rate, and you generally don't get a tremendous improvement in vision, just a stabilization of vision. And so I generally will operate if there's symptoms, the child is symptomatic if they're old enough to describe symptoms, and I would want to see a progression of the visual loss and persistence of fluid that doesn't reabsorb after a period of observation, usually 3 to 6 months or even longer. So I'm quite conservative with these cases. David, any comments about optic pit maculopathy?
Yeah, these can be very challenging cases to address. My interest is as with medical retinal specialists in general, is the mechanism of the fluid accumulation. But in terms of treatments, I think there have been various options that have been written about. But by and large, I think these patients often end up having to have vitrectomy, gas, and laser in order to help expedite resorption of the fluid. But in this particular case, there was significant improvement. Did the fluid completely resolve, Robert?
So so he's now, I did the surgery a month ago. So I was observing him since around end of November, and in early February, he's basically, his vision was quite poor, right? Overall, like count fingers like at baseline already. So basically what we were kind of trying to do with him is just for him to figure out his like central scotoma, whether that central scotoma getting larger or smaller. And that was kind of the cue for whether we were going to proceed with surgery. But the picture to the right is 1 month post-op, right? So there's already some improvement, and I'm hoping that it's going to kind of continue to improve over the next couple months or so.
So you did a bunch of different things here: vitrectomy, gas, glue,
that's
and
right. That's right.
It's hard to know exactly what was the real key factor here.
Exactly. So yeah, that was kind of bringing up my next question to Rajiv as to kind of what's your recipe, or do you have one for these types of cases?
Yeah.
In this case, I've done an island flap that was tucked into the pit. The reason for the Tacil glue is I found that in previous cases where I've done that, the flap can oftentimes very quickly, evulse itself during the air fluid exchange if you're not absolutely very, very, careful, but also lucky to some degree. And so the Tacil was to try to really hold that into place as much as possible. But what's your current recipe with these patients?
Yeah, I mean, I like the ILM flap technique. I generally like to try to drain the fluid through the pit. I used to do laser around the edge of the pit, but I've kind of stopped doing that. And ILM peel with gas and face down positioning. I think all the other stuff is, trial and error really at this point. So we're just about close to the end here. I'm going to go over one last case of a patient with a rhegmatogenous retinal detachment who presented 1 month post-op. You can see that their retina is fully attached, but the patient complained of significant distortion and had significant vertical and horizontal metamorphopsia and significant anisoconia. And if we look at the fundus autofluorescence imaging here, you can see these vessels, which are called retinal vessel printing or ghost vessels. And this signifies a displacement of the retina, an inferior displacement of the retina that has occurred following retinal detachment repair. And, we've done a lot of work on this, and we're collaborating with David's group as well in trying to understand this. And, retinal detachment surgery used to be something where you just look in, and if you say it's attached, it didn't matter what the patient's vision was. You did your job and that was it. But we're now at a stage where we're trying to refine our techniques to improve functional outcomes for patients. And, we call this a low integrity retinal reattachment. So the retina is attached, but it hasn't returned to its normal baseline position. And we found that this is associated with abnormalities in the outer retina, specifically the ellipsoid zone and the interdigitation zone. And that was a patient who had vitrectomy surgery. And to give you the opposite end of the spectrum, this is a patient who had a pneumatic retinopexy where the RPE pump reabsorbs the fluid rather than a forceful reabsorption of fluid internally during vitrectomy surgery. And we think that this natural reabsorption of fluid leads to a more natural realignment of the photoreceptors. And you can see in this case, there's a nice preservation of the outer retinal lines there. And we call this a high integrity retinal reattachment. And typically these patients have better visual acuity and less vertical and horizontal metamorphopsia and anisoconia. So this is something that we're currently interested in. And in a patient who has retinal displacement, you can often see these hyper-reflective lesions consistent with outer retinal folds. And something that David and I are working on is looking at the en face OCT in patients who might have displacement following retinal detachment repair. And it's interesting, in this case, you can see this outer retinal fold aligns with this area of hyporeflectivity on the en face OCT. And one of the potential theories is, could there be a stretching? So perhaps what you're seeing is the fold, and then the stretching on either side of it might correlate to that hyporeflective lesion. You know, David, I know you've had an interest in photoreceptor and recovery of the outer retina. Do you have any comments on that?
I think that that's amazing work that you've done, Rajiv, using advanced retinal imaging to really identify a problem, and then using your surgical skills to provide a solution and a remedy. So I really love how you've dovetailed advanced retinal diagnostics with a therapeutic options. So I'm just happy to participate and collaborate with this excellent work that you've started. What was really cool in that retinal printing example you showed, it wasn't just inferior displacement, it looked like it was nasal displacement as well. Is that, or actually temporal displacement as well, inferior and temporal. Is that usually the case? Why does it go in that direction?
Right. So it's actually usually inferior. And we've discovered that the retinal displacement is occurring primarily because of a subretinal fluid flow. And so as the fluid is being drained out, the direction of that flow is what determines the direction of the retinal displacement. And that's a very astute observation, David. In this particular case, I didn't get into the details, but the perfluorine heavy liquid was used, and the drainage of the fluid occurred in that direction, inferiorly and temporally. And so we feel that the retina got stretched in that direction specifically. So
it's not always temporal. The inferior location seems to be more consistent.
Yes, and that occurs even without perfluorine liquid. When what happens at the end of surgery is you have this residual fluid there, and as soon as you put the gas bubble in and the patient changes position, the fluid gets displaced inferiorly, and that usually leads to an inferior stretch. So I would say 90% of the time you're getting this inferior stretch.
That's pretty cool.
Yeah, I'd like to thank Robert and David for participating. We're running out of time now, and I want to leave time for our glaucoma colleagues to talk about OCT in glaucoma. But thank you, David. I know you have another webcast, and we're going to call on you again because it doesn't sound like we'll be back to work for a long time. So
it was nice to see you guys. Ike, thank you very much and Jeb, thank you very much for arranging this, and it was great talking with all you guys. Thanks very much, Rajiv. See you.
And thank you
very much, David.
Thanks, everyone. It was great talk.
And thank you, Rajiv. We had about 750, and we got about 700 people still on. It's from around the world. It's pretty incredible. So thank you for sharing. I'm going to launch a poll here while we're switching over. And Matt, if you want to just maybe screen share on yours, and Rajiv, you probably stop yours. My question here to you is, where are you from? Where are you calling in from, or where are you watching from? So I hope that you can see the polling questions. Are they on your screen? But a bit of a glitch with the polling sometimes.
Yeah, I don't think it's showing up here.
No?
No, it's not showing up.
Let me just relaunch it again. We've had to sometimes Zoom's a little bit glitchy with this. Let's relaunch because we only had 2 people voting. All right, let me just relaunch this here again. And can you see it now?
Yeah, it's not coming up.
Yeah, we've had some glitches on this, but we'll probably have to. I'll try one more time. Anyways, I do want to thank our Retina crew for doing a fantastic job, both some of the basics as well as some of the cutting edge work that's being done, combining surgical and treatment with OCT. So thank you. Of course, glaucoma always seems to go last. I think, there we go. Now we got some votes coming in. But we've got a great crew here. I want to thank Matt Schlenker for leading this one. We got Dima Kalash from Montreal. Jeb's here. I may call on a few others. I see that Sanjay Asrani is on the line somewhere, and so is Carla Siegfried. So if you guys are okay with it, I may call upon you to answer some or be a panelist. But I'm gonna soon hand it over to you guys in a second. Let me just stop the poll. We're got a pretty wide group. We even got some folks from let's see. Let me share the results here. Okay. Let me see if you can. Can you see the results, everybody? Jeb, can you see it?
So mine, it shows that it's, yeah, I can, no, I don't think anybody's seeing it. If I look at the chats, I think I'm seeing something different because, you know, of our accounts.
Yeah, this polling thing. Let me just try one more time here. Dima, tell me if you can see it. So basically, we had about 40% North America, 30% Latin South America. It's always a close neck and neck with you two. Europe, we had 15%, Middle East 9%, Asia 5%, Africa 2%, and one person from Australia. So thank you for joining us from Australia, New Zealand. All right, well, let's hope these polls can work. But I want to hand it over to Matt. So Matt, thank you for joining us. Matt's got a bunch of interesting cases in glaucoma. So thank you, Matt.
Yeah, thank you, Ike and Jeb, for this wonderful opportunity. And thank you for everyone who's participating. Obviously, our minds are with those who are dealing with this pandemic. In fact, we had another distinguished panelist who is dealing with a loved one who has COVID, unfortunately. So, but thank you again for all of you, and particularly to Dima. I don't have any, I don't think any relevant disclosures to this particular talk. And here are the learning objectives. I think we may end up posting these online as well. And I'll go through these more at the end, I think, to synthesize and summarize. And we're gonna try that polling again. I know there's been some glitches, and we're gonna see a lot of red on our OCTs. And I want to also note that those of you who are interested in the retina, we're gonna spend a lot of time working in the retina, in the macula, actually the inner retina. We've talked a lot about the outer retina and the vitreous today. Let's just start here with this case. Ike, are you able to put up our poll?
Yeah, let me just launch it right now.
Okay, so you guys may have to move the poll a little bit away. I just want to get a sense from everybody. So we see some red here on the deviation map, and we have 4 options here. And I think this is a general way to approach glaucoma OCT. Is this red artifact? Is it normal anatomy? Is it non-glaucomatous pathology, or is it glaucomatous pathology?
Okay, let me just, I'll just end the poll now, and maybe you want to get the panelists up on that.
Okay, so we had 39% of people say this is normal anatomy. And then we had 25% said this was glaucoma, 20% said non-glaucomatous, and 16% thought it was artifact. So I'll just spend a little time here, and then we'll get Dima to comment on my approach. And I'm going to encourage everyone to stop being stockbrokers when they look at these printouts. What I mean by that is not looking for red and green and numbers, but actually more be like a radiologist. A radiologist is going to look at this, and they're going to want to actually look at the anatomy. Okay, so I like to start with the thickness map. Just going to see if this, you look at the thickness map, and here we're just getting a general sense for symmetry. We're getting a general sense for any artifacts. And then I go to the deviation map. Now the caveat with the deviation map is that this is the deviation map here. All of our different so I'm using Cirrus, but all the different companies, the normative databases are small and they had a lot of restrictions. So keep that in mind when you're looking at the deviation map. And then I usually go down to this tomogram here, the circular tomogram. So the circular tomogram is taking this purple circle, which I'm circling, and it's putting out into a vertical line. And then you can actually assess the segmentation, and you can find the RNFL bundles. So here are the RNFL bundles, the main RNFL bundles, and that's a coalescence of our raphe as they come into the optic nerve. And so once I've looked at that, the main area that I end up focusing on for many of the OCTs, assuming there's not an artifact through that circular tomogram, is this RNFL thickness plot. And maybe I'll get Dima, why don't you tell us what you think about the RNFL thickness plot, and then any other general approaches you would take in looking at these scans.
Hear me?
Yeah.
Yeah, sure. Thanks for having me, and I hope everyone's staying safe. So yeah, exactly what Matt was saying. I agree. That's kind of the way that I tend to look at things. Obviously, we also want to just make sure that the signal strength on all of these OCTs are good. So for the regular OCT Cirrus, anything above 7, we would say that it's a good OCT. 6 is about borderline, but anything below, it's a poor signal strength. So if that's the first thing that I actually look at, especially if it's not your own team that's doing the OCT. So it's very important. So with regards to the RNFL thickness, so normally we like to look at having these two large peaks in terms of the superior and the inferior peaks that we see on the RNFL thicknesses. However, what I see on this OCT is what we kind of have like what we call a double hump. And I think glaucoma specialists like to use double hump because they also use it for gonioscopy on plateau irises. But in this case here in the superior area, we see this double hump thickness of the RNFL. And we can see that very well, actually, Matt highlighted the RNFL circular tomogram. So in the terms of the superior bundle there on the left side of the tomogram, there's, rather than being one full thickness nerve fiber layer bundle, it's actually two. So in this case, it looks like there has been a splitting of the a superior RNFL bundle insertion, basically. Other thing that I do look at actually with regards to the actual data numbers, I do tend to look at the disc area. Not necessarily that it helps me, but it gives me an idea of maybe why these patients present, because people tend to kind of worry about the size of the disc and cup ratio when they're large discs. Another thing to note for the RFL thickness maps is you're going to get the thickness basically shows that the red ones tend to be thicker. So I like to see that there's these two peaks, superiorly and inferiorly of red or yellow, which to me makes it seem that they're more or less having thick nerves in that area. So that tends to correlate well in this case with the deviation map, where you see that there's quite thick superiorly and inferiorly, but the deviation map, because there's been a bundle split in the bundle, is going to miss that part superiorly on the deviation map, which is why it's giving you a red area here, which means there's actually difference from the normal.
Thank you, Deeman. I'll just highlight too, something else that you can look at here is look at the vessels. The vessels are way out. There's a huge divide between the two vessels, which again is just more evidence that this is possibly not pathologic. And something else to mention is it's very unlikely that you're going to get an RNFL defect there as your primary presentation for glaucoma, especially in such a symmetric fashion. Another way to corroborate this, and this is where we get into the retina, is we're spending more and more time looking at the ganglion cell. And I would argue that this is now part of a standard glaucoma workup, and you're going to see that permeate the cases where this can be helpful to either confirm your hypotheses or potentially refute your hypotheses. And you can see here quite a nice thickness deviation with excellent segmentation in this young patient who's able to sit still for the scan. Okay, so you can choose your learning style here. The left is actually a mapping out of the various RNFL distributions that you can get. The right is just, again, looking at, there's a lot of different ways that people can put their hair. There's a lot of normal out there. And you can see, I'd actually asked Ike to wear pigtails for this because I thought that could be a split bundle. And we searched social media for pigtails, couldn't find any. I guess this one's the closest thing to being a split RNFL defect here. And then I said other people just have a much different distribution in their RNFL.
So,
Ike, any comments?
People are asking about the percentages of normal that we see these in. And I think there was a study that was done in Turkey that showed about 15 to 20% of the normal population might have these split bundles.
Yeah,
sorry.
I'll just go back. I mean, you can see it here in the normative database. You know, it's subtle, but it did come through in the normative database. It's just not as pronounced as what we're seeing in this particular patient.
And there's actually been histological evidence of this. So it's not just artifact on OCT. There's actually histological evidence of these split bundles.
Okay, so Ike, can you launch the poll? It's going to be the same 4 questions.
I just launched it here. I thought you were going to launch a poll on what hairstyle was the best, but I guess we're past on that one. Hopefully you can see the poll. Same questions again. You guys seeing it or no?
No.
Yeah, it's not coming out.
I'll just relaunch it again. Yeah, it is pretty glitchy. Let's relaunch.
Now it's there.
There we go. Okay, so we're seeing a lot of red, inferior and superior poles. We're going to talk about the macular vulnerability zone in a little bit here. What do we think?
We got about 700 people voting here, so it's taken a while to get up there. But looks like I'll post it shortly. 40% are voting glaucoma, with about 27% saying it's normal anatomy outside of the database, and then the rest are artifact or non-glaucoma. Let me share the results here for everybody. Can you see the results?
Yes.
Yeah, it's showing up.
Okay, so the winner in this one's glaucoma. Jeb, do you want to share why people may think this is glaucoma?
Yeah, so I think, a lot of what people are probably looking at is, if they're looking at the deviation map, they're seeing a lot of this red and kind of more of that typical pattern, the superior and inferior thinning. But I think one thing that gives us a big key here is if you look at the T-SNP plot, if you look at the peaks of the actual nerves, some areas are even super normal. And overall, this just looks like the RNFL is very temporal in terms of where the insertion is. You could argue that for the right eye, which is the solid line there, maybe the superior area looks like it's a little bit thin if you compare especially to the left side. But overall, I just find this is probably just a case where the RNFL is inserting quite temporal. And that I wouldn't be particularly worried about glaucoma necessarily in this case. Other things to note here is that these are rather small discs. And typically when I kind of see this type of picture, this more temporal insertion of RNFL, smaller discs, I kind of wonder if this is maybe a hyperopic patient. We don't always have the clinical picture for these patients though, given we're just seeing an OCT, but it makes me think more of that.
Okay, thank you, Jeb. So yeah, I'm in the camp that this is particularly for the left eye, unlikely to be glaucoma. I think we see a very temporal insertion of our RNFL here, which is often the case with our myopic patients. I like, that you spent a lot of time focusing on here. There's been some comments I saw that some people were concerned about the signal strength, and I agree you do have to be careful, and you can see that really shines through on the tomogram here. What I would say about the signal strength, it is something to take into account, but I'm much more worried about just looking on the deviation and the thickness map to make sure that that there's not artifacts in my circle scan, and we're going to see some artifacts later. I do think one issue here could be this asymmetry. I'll just circle it here. Superiorly between the right and the left. And this could very well be a situation where we call green disease. Our normative database has such a wide variation of what normal can be that if someone starts up here, they can actually lose 10, 20, 30 microns and potentially have a problem. So my takeaway from this case is that this is the anatomy for this patient. They have a very temporal insertion of their RNFL, and I'd be a little bit suspicious for glaucoma on the right side, and I think it is worth following.
Matt, I'd just like to add there, if I can, the thickness map actually shows that very, very well. So if you look at the left eye, the thickness map there, the superior part is like orange, red, and very, very nice thickness, and you can see it actually inserting temporally in that nerve. Mm-hmm. While on the right eye, you have a great one inferiorly. There is a little bit there superiorly it's less thick. So yes, I agree in that case. There is some asymmetry between both eyes, but this is very typical of temporal insertion of the nerve fiber layer bundles.
Okay, so at least worth repeating, if not following. Now, the good news is we have some of these patients are getting 1 month assessments by our retina colleagues. And this is, again, a reason to start getting more and more familiar with ganglion cell analysis. So I do have this history on this patient that shows while they're getting assessed on a very frequent basis for retina-wise, the ganglion cells have been quite stable over time. So I'm reasonably reassured by the anatomy, except a little concerned about the superior right bundle, but I'm definitely reassured by this ganglion cell analysis. And luckily, the ganglion cell analysis is less prone to these differences in anatomy. The hairstyles are a little more uniform for the ganglion cell. Okay, can we put the poll up for this one?
Here we go.
Okay, I'm seeing a lot of red again. It's also a little bit of a shame that the thickness map red is good and then the deviation map red is bad.
Yeah.
Wouldn't have been my preference, but And something else that we can talk about later, and really it's been Don Hood who's popularized this. I think it's a shame that the temporal is on the periphery of this main plot that I like to focus on. Okay, here we go. We got our results.
Looks like you got a close vote between non-glaucomatous or normal anatomy outside the normal database.
Okay, Dima, you want to share your thoughts? I put the ganglion cell up right away as well.
Yeah, so again here, I do see, just by the thickness map, there's quite a thick superior and inferior bundles. If I look at the deviation map, when I see this kind of diffuse loss there, I tend not to think of glaucoma unless it's very late stages. So that red to me is a bit like not normal for glaucoma. There, in terms of the RNFL thickness maps, there's some nice peaks there, superiorly and inferiorly. But if you see, it's kind of shifted. So rather than being the typical, we're over the temporal, supratemporal area, it's shifted towards the nasal area. So in this case, it looks like it's more of a nasal insertion. One of the parts that I'd like to just look at there in terms of the, yeah, exactly, in terms of the horizontal tomogram right there at the insertion right before the nerve, that looks a little bit, there's a little elevation there if you compare that on the left eye to the right eye. And I would be a little bit suspicious of maybe a drusen there or something, but I'm not, I mean, you can't be 100% sure, yeah. And you can see it a little bit on the nerve in the deviation map. There is some elevation there.
Okay, thank you. Yeah, I would agree. I think this is another example. This is more of a nasal insertion, which sometimes we see in our hyperopic patients, but not always. I think the scary one for the nasal insertions for me is, again, we're going to be looking for focal damage in glaucoma in these areas, okay, which is these inferior and superior macular vulnerability zone. And this is going to be hard to detect because we don't have a lot of tissue there. And I have been burned. You know, I have one case in mind that I knew that they had a very nasal insertion, and I was kind of watching over time, and they kind of, the red area here started to enlarge. And what was happening is that they were developing more glaucoma in their inferior pole, but it was very hard to see.
This is Sanjay here. If I may add a few points.
Hey, I just got, we got a special treat here. Okay, special treat. We have one of the geniuses in glaucoma, one of the geniuses in OCT from Duke, Sanjay Asrani. Thank you for joining us. I just brought you in. Please,
Sure,
Sanjay.
thank you so much. I just wanted to echo a couple of things that Matt already mentioned, actually, and that is that the shift nasally here in this case is more typical of a hyperope, like he was suggesting. But I'd like to point out that are you folks able to see my mouse? Maybe not.
If you go to view options and hit annotate on the top of your screen, it says you are viewing Matt Stenker's screen. And if you hit annotate, you'll be able to then annotate.
If I do
up at the top, view options.
Yeah.
And then go the menu annotate.
Okay.
Yeah.
Okay. So
just don't draw any kind of, you know, like pictures.
Yeah, cartoons of your face. Yes. Sure. So this picture and this picture, I typically look at the symmetry here rather than this one. This one is comparing to normative database. Here you can see the symmetry yourself. The other thing to notice is that this is an artifact right here. If you're able to make it out, I'll erase that.
Yeah.
You can see that there is a movement there. The other thing to notice is that in this one here, you can make out that the boundaries have been correctly identified. Sorry, I've been asked to change the color of my, okay, I'll change the color. These boundaries here have been correctly identified. If you go back, Matt, to the previous one, the previous case, if you don't mind.
Yeah.
Yep. This one, I want you to notice that this boundary here may not necessarily be correct because the signal strength is so poor the software may not be able to capture that lower boundary. So it may appear artifactually thick right here, rather than it really being thick. Because of this artifactual thickness, you're going to see an asymmetry right here. Yeah. So just keep that in mind. This is a very typical myopic nerve, as you already alluded to, being a temporal shift. And once you notice that there is a problem here, you therefore will disregard the top portion right here. So as you can see, the cups are small. So the optic nerve itself is atypical of myopia, but the nerve fiber bundles are very typical of myopia. Just wanted to add those things. Thank you.
Sanjay, thank you so much for participating, and amazing that you can just on the fly, you know, look through these so quickly. Thank you. And I completely agree with what he said. You know, myopia is challenging. And yes, usually the nerves are not necessarily small like these ones, but don't give up on myopia. You know, Don Hood has a very good paper saying that over 90% of patients, you can still glean something useful. We have a lot of different metrics, and there's always something. Yes, the signal strength's not always good. Yes, we have Z-axis artifact, you know, peripapillary atrophy, which we're going to discuss, but I don't think we need to give up. It's not just about the visual field, because it's often too late by the time you see it in the visual field.
So Sanjay, stay on, of course, because we'll have to get your input as well for the next ones.
Yeah, and I just want to highlight, this gets into this myopia issue a little bit. This is some of our own data from Toronto. Just looking at the spherical equivalent, which is a proxy for myopia, and the RNFL. And you can see here that there's about a 2 micron RNFL thickness difference per diopter for, these are primary angle closure suspect patients, which often have reasonably thick RNFL, a little on the younger side. So it's just something to keep in mind that myopia, a lot of this is actually a magnification effect, and not necessarily, if you adjust for the magnification, there's not as much of an effect, but at least clinically, with the current modalities that we have, it's something to keep in mind that if you have a -10 myope, do not be surprised if their thickness is overall low. So again, I'm going to also caution people to not just look at the averages anymore. The ganglion cell analysis has a less of this issue, another reason to start looking at it. Age is another factor. Now, age, it's also about 2 microns per decade loss, at least in this patient population. It's been higher in other patient populations. And this is true for both the RNFL, which is shown here on the scatter with regression line, and the macular ganglion cell, or the ganglion cell analysis. And this is just an example. This actually happened to us in clinic one day. So I'll just show you. You see a lot of red here, diffuse red, suspicious for glaucoma. And let's look at this patient's scan 6 months prior, okay? And if you focus, and I agree with Sanjay, you gotta be careful just focusing on these deviation maps. If you focus on this, this looks quite concerning, okay? So we didn't have a lot of red, and now we have a lot of red. On the other hand, if you go to what I like to look at, which is here, and you look at the actual plots, you can see that they look quite similar. So Dima, you want to share what happened here?
Yeah, so again, this is one of the important ones where you have to actually look at the make sure that the patient's the right patient's there, so date of birth as well. Just here in terms of the signal acquisition is probably, again, people are going to mark that it's not perfect. But what we can see here is if you look at the normative database for someone whose date of birth in 1999 and someone whose date of birth is 1929, obviously the normative data is going to be lower. And so if you're pretty much, if your curves are still the same, but if your normative data is either lower or above, it's going to tell you it's red or not. So if you look at the 1999 one, the normative database is obviously higher because you expect someone to be younger to have thicker nerves. And so if you compare it to someone who's born 1929, that red artifact red disease is going to be apparent.
Yeah, thank you. So ideally you have it set up so that you're not manually inputting dates, because this 9 that was inputted instead of the 2 significantly changes the deviation map profile for this patient, and that could theoretically change someone's management. Okay, so here I'm just gonna, okay, we got the poll again. So let's look. So I know for some people it's hard. Focus on the one on your left screen, okay? This one in particular.
Looks like the majority are saying, I'm just going to report the results, that a majority are reporting or voting for artifact, Matt. I'll just share this. I'll just share it here.
So yeah, this is a fairly classic artifact. So yeah, 70%. Okay, so we'll just go through this quickly and look at the implications. So when we're looking at our thickness map, we see something black here, which represents, an acquisition defect, which is red here. And then you go down to your tomogram and you can see that there's no way to segment because there's actually no data acquired in this area. Now, the really disappointing thing with our current modalities is even though we know that the lowest that the RNFL can go is approximately 50 or 60 microns, when you have an acquisition defect like this, it goes all the way down to 0. And this is just another reason not to focus on these averages, to not spend a lot of time on these, because that average is going to be quite weighted by this area that is 0. So we repeated this scan later, and what happened with this acquisition area, which was actually a large floater, is it moved right into the nerve. The good news about that is now we have an unimpeded circular tomogram and we get a much better scan. The bad news, of course, is that it messes up our disc and rim area, which I don't focus as much on anyway. But yeah, these floaters can come and go, and you just have to make sure. And I would hate to look at this 87 versus 101. You know, Sanjay's done a lot of research showing that, 10 microns for sure, if not 5 micron difference is statistically significant. But here we're just seeing it's because of this floater. So this one here, I don't think we need to do a poll for this, Ike. I'll just skip out of this. I just want to focus on a few things. We've already touched on myopia. Now, this is a patient, without going into all the details, who I do think has glaucoma. And there's kind of 4 things to look at here. One is having to deal with peripapillary atrophy. It's sometimes hard for the machine to delineate the disc margin and the rim margin, which is another reason why I don't focus a lot on the neuroretinal rim thickness. Something that's nice for these scans is that the peripapillary atrophy for many patients is actually within that 3.46 millimeter area. And this was by design, just looking at peripapillary atrophy. So here I'd be a little bit suspicious that the segmentation is going to be an issue due to the peripapillary atrophy. So I would have to watch these areas closely. But it does seem like we're getting some segmentation in these areas. Another area of concern in these myopic patients is this Z-axis issue. And this is manifest right here in the circular tomogram, where sometimes there's such a depth to this area that we can't get it in a single scan. And of course, if that Z-axis area goes through your circular tomogram, you're going to have the same problem that we saw in the last one, where your RNFL is going to go to 0. So you have to keep these things in mind with the myopic patients. I would not give up, as I said before, but you do have to be very careful in interpreting these scans. And again, not focusing on these averages, which can mean very little. I don't know if Sanjay or Dima have any comments on this one.
This is Sanjay here. I'd like to make just one quick comment, and that is if one looks at the upper panel right here, one can see where the losses of the nerve fiber layer are. That will match up with the visual field losses.
Yeah.
And similarly, in the other eye, you can see these losses right here. So since the disc is problematic in such cases because it is tilted, it's got peripapillary atrophy, it is better to ignore the optic disc and just look at the radiations and identify where the losses are. And the losses that you will see, I'll erase it again just so that you can make out this loss right here. Sorry. This one. Okay, I'm trying to get out of my eraser, but it won't. But basically in the inferotemporal quadrant of the left optic nerve, you can see that some of the nerve fiber bundle losses are towards the fovea, exactly right there. So that area tells you that that's why this patient has a superotemporal superonasal field defect that is actually encroaching fixation. Just wanted to share that in.
Thank you. Okay, so I'm just going to switch my screen share here, and I want to show my workflow. I think everyone's going to have a little different way that they do it. As you can see, I use the Zeiss platform here. And there so I go to the structure function GPA within Glaucoma Workplace. And what I like about it is they can really capture basically everything that we're talking about. You can use your statistical measures if you so choose. You can actually put the ganglion cell on here as well. So this is the superior ganglion cell. This is unfortunately a patient who's refused surgery over time and I'm watching her go blind. She's been sent for second opinions as well. And I thought this would be helpful to show her, and I have shown her, but it hasn't led to the result that I would like. It's again, you can look at, I start with the same things that we're looking at before. So sorry, I'm just going to go to the thickness here. You can see general decline in her thickness. You can see the deviation from normal is getting worse. You can see her ganglion cell getting worse. I don't like looking at the deviation map for the ganglion cell. I'd like to look at the thickness map. And then I really like to look at the T-SNP plot. And I said if I was starting this at the beginning, I'd probably go to an end-stin plot, which you can switch here in Form now. And you can just look at this over time. So what will happen is every time you click on one of these images, you can see that T-SNP plot over time, which is a way that I like to follow patients. It's honestly probably the main way that I look at it. And that's, again, assuming that we don't have any acquisition defects. In fact, in her right eye, for this patient, she has a little floater here, and you can see this floater, it's moving in and out of our circular tomogram. And you can see that. So you can see one of the baselines has that little divot representing the floater, and that floater comes in and out. Here it came in, it's just in a different location. So you can just kind of subtract that out in your brain while you're looking through these. So I don't know if Sanjay or Dima have any comments on their workflow when they're looking at patients.
I use Forum as well, so I kind of do the same thing. I guess it just depends on what you have at your office.
Yeah, and a nice thing here too is you can just look at either the superior or the inferior, both in terms of the RNFL thickness and the mean deviation. At least this is how I have it set up. And we're actually going to a 6-panel system in the latest Glaucoma Workplace, which I think is, for those of us who like to look at a lot of numbers, will be helpful. So I'll just switch back now to our PowerPoint.
So Matt, there is a question on the chat about how doing serial nerve optic photos is actually better to follow up myopic patients. What is your thoughts on that?
Yeah, I think OCT has not completely replaced photos, though I do think that the OCT can still have a role in the myopic patients. The myopic patients, I think some, even by photos, it's hard to identify our nerve and our disc area and our cup area. I do think sometimes you can see the RNFL losses that Sanjay was showing on RNFL photos, but we could see them on the OCT as well.
Yeah, I agree. I definitely think for patients who are myopic, I do tend to rely a little bit more on the clinical exam in terms of looking at the optic nerve, because you can see the thinning or cupping a lot better in these when you're looking at it en face on the exam rather than the OCT.
Ike, you want to do a poll for this one?
Sure. Let me see if I can launch this one and get you guys in there. Let's launch poll. Can you let me know if you can see it? For some reason, does it display on your entire screen?
Yeah, I can see it.
I think for the iPhones it does, but if you're doing it on computer, it's on part of the screen.
Okay. So you're getting a lot of people, 85, 90% are talking about glaucoma here.
Glaucoma?
Yeah. I'll just share that. I'll share the result quickly here if you can see it.
Okay. I'm going to try to change your mind. And I'm going to ask our retina colleagues to help us. Okay, so the few things that are a little concerning for me. One is this is quite diffuse to be glaucoma. It's so asymmetric, and this is not just the macular vulnerability zone. This is all over. Okay. The other thing is when I look at the ganglion cell, yes, there's loss, but it's not just in the inferior quadrant. It's not respecting the meridian that we're used to seeing. And then now, why don't I ask Robert, can you maybe comment on the retina here?
Great case. Yeah, so certainly what we see on the retinal B scan of the left eye is that there's quite a bit of inner retinal atrophy, right? And that's again affecting the infratemporal quadrant more so. So certainly kind of brings up the differential of intervascular disease, like a retinal vein occlusion, or even maybe a previous retinal artery occlusion that could have been within that quadrant as well, right?
Yeah, thank you. So this is where we do have to look at our traditional retinal scans as well when we're in doubt, when we see a situation like this. And I like to use this printout, the macular cube analysis that looks at the thickness from the ILM to the RPE. Glaucoma, and maybe I'll just skip to it. You know, this is a slide from Don Hood. Glaucoma is very much an RNFL and a ganglion cell problem, as opposed to an internuclear and a receptor problem. This is if you take a model and induce glaucoma, the receptors actually stay largely intact, as does the internuclear layer. It's the RNFL and ganglion cells that are damaged. So if you see a lot of damage of the photoreceptors and atrophy, it could be also glaucoma, but it's not just glaucoma. And then you have to start thinking about other causes. And I think, you know, Robert already gave us a little bit of a differential. I look back in this patient's history to look previously, and this is what the patient looked like before, which is a little more in keeping with what Robert was saying, more in keeping with a vein occlusion. And you can be a little bit tricked on RNFL because the RNFL can be swollen in the acute phases of a vein occlusion.
Matt, if I may add a couple of points here.
Sure.
And that is, and once again, let me start the annotation so that I can, you see that the patient has, if you go back to the previous slide, of course. Yes, you see that everything else here, including the right eye, is completely normal. In the left eye also completely normal. It's only here where it starts going into the red. So when it goes into the red in only one quadrant of one eye, it is typically not glaucoma unless it is at a very early stage. So if you have so much loss and it is only in one quadrant, you have to rule out non-glaucomatous conditions first. And you can see that even here, the entire macular thickness in this region is completely normal, and this one is completely abnormal. So whenever you see such a cutoff, it is usually vascular. And one of the things that does this is also a NAION. So besides retinal vascular occlusions, because that will cause a significant atrophy of the inner retina. Thank you.
Yeah, thank you. I completely agree.
Matt, some people are noticing the cup to disc ratio that's quite large on that OCT. I think maybe that might have been a reason why some people were thrown off with regards to the glaucoma or not.
Yeah, I mean, when you have a disc area of 2.4, which is really on the upper end, I'm not too worried about in general, I'm not too worried about the cup to disc ratio clinically. The OCT over time, I think I would be concerned a little bit, but that's where I think the importance of the RNFL and the ganglion cell analysis, I think that's becoming more and more important. But yeah, I agree that, you know, cupping can be physiological cupping. It can be hard to differentiate from glaucoma. And here again, I just want to show that some of these patients who have retinal disease, they're getting a lot of OCTs, and we can pull that data from the regular macular OCTs they're getting. This patient did have a little episode of swelling in between injections, but you can see quite a bit of stability here. Okay, maybe this will be our last polling one. I know we do got to keep it moving here. Ike, you able to pull up the poll?
Let me launch it here. Let's see if we can get it. Can you see it up there? Yep, we're getting some responses.
Okay, and the question is really for the right eye.
So you're getting 50% glaucoma, about 30% non-glaucoma. It's increasing on the glaucoma side. Let me just share it. We still got 600 people on the line here. A lot of people here, so.
Okay, so it is a glaucoma session. So 55% think glaucoma. I mean, I think there's reasons to think glaucoma here. We look at our thickness map, and Sanjay pointed out, you know, oh, sorry. Those look like RNFL bundle defects to me, okay? When I look here at the deviation map, you can think about this area here too, a little bit suspicious, okay? This is where the red comes right here on our RNFL thickness plot. Segmentation looks not bad here, okay? One thing, you know, maybe Sanjay can comment on this as well, because I haven't seen it well documented in literature. When I see on the deviation map that the red is just in one area and it's not going all the way, I see that often in my PRP patients or in my vascular patients as well. And I get a little bit suspicious that whatever I see up here should also correspond to a deviation here. So that was my first clue on this one, that it's maybe not necessarily glaucoma. I want to, here, let's look at this total profile. I generally don't use this when I'm actually assessing the patients, though it is a nice summary printout that Zeiss offers. And you can see here the ganglion cell analysis. If you're going to have that much of an RNFL defect here, generally speaking, the correlation between these two is quite high. So right here, I'm thinking there's maybe a little bit of an issue with my diagnosis. On the other hand, I'm looking here now at my function, and I'm seeing a visual field defect that could very much be glaucomatous in nature and very much in keeping with what I'm seeing on the RNFL scan. And I'll just blow up this. This is another ganglion cell analysis of the patient, so another macular OCT, and we're seeing this large artifact up here, which again is equivocal for glaucoma damage. Sanjay, any comments on this?
Yeah, let me just point out a couple of things. One is that if you look in the left eye, you will see some significant movement artifacts. So just keep that in mind. There are movements here and here. That is 2 times when the patient blinked or moved the eye. And the second is that, you know, retinal chorioretinal scars in that region superotemporally, where you were pointing out right here, can easily masquerade as glaucoma. So a fundus examination, a dilated fundus examination is absolutely necessary to confirm, because the loss that we are seeing in the ganglion cell layer is highly atypical of glaucoma. Additionally, the loss is only in one quadrant of one eye. So yes, I can understand why most people will think that this is glaucoma, but your point is so correct about the fact that the abnormality is not extending in this region.
So Sanjay has never seen these slides. This is his first time seeing it. Maybe we'll get Rajiv to comment on what he sees here. I think you're on mute, Rajiv.
Rajiv might be. might be off right now. Maybe we'll get Rob. But
Yeah,
the one thing I was going to
so-
add on that one is don't forget, like, I mean, the clinical exam is going to be critical. And if you look at the disc, if that truly is that much RNFL loss from glaucoma, that disc should be cupped out superiorly. Again, we don't have a clinical picture of the disc, but based on this and based on the image, OCT image, it looks like it's not that cupped up there. So that's another
Is that, does it look like, if you go back, was that a benign sclerochoroidal calcification lesion there, or some sort of chorioretinal atrophy?
Yeah, so I contacted the retina doctor because I wasn't sure when I looked at it, and it was actually an extrafoveal CNVM. The patient's a GP, and they decided together to laser this extrafoveal CNVM.
Okay. Right, yeah.
So I think, Sanjay, just looking at the OCT, you know, there's a lot of questions on here asking for the clinical picture and everything else. And I agree that, you know, right now we're focusing on OCT. At the end of the day, we need to focus on the clinical picture, but we just had, granted he is an expert in the field, pretty much diagnosed this just looking at the OCTs. So I just wanted to drive home this point that glaucoma defects follow the patterns that we're seeing here in nerves. And if they're not following a nerve pattern, both on the RNFL and the ganglion cell in the absence of artifact, we need to be suspicious of whether that's true glaucoma or not. And Donald Hood has really popularized this phrase, macular vulnerability zone, showing the areas where we're most likely to get the glaucoma. This is the first initial presentation for many patients. And as Sanjay also said, maybe I'll just skip to this. Thankfully, our central vision is usually intact in the end until they start getting this temporal bundle here, which starts to go. And this is, you know, possibly an evolutionary manifestation here, and why many of our glaucoma patients do not complain of vision loss until the very end. And this is just our classic printout, showing kind of a classic RNFL loss in the macular vulnerability zone, notwithstanding some peripapillary atrophy here. And this is what it looks like on my favorite printout, where you should see it on the infratemporal region on your T-SNET plot. So just want to add a little bit of nuance here. I don't know, Ike, do we want to do another poll? It's getting a little bit late.
I may get you just to maybe go through it, Matt.
Yeah, or we can get Dima and Sanjay to comment on this one. The left eye to me looks fairly typical for glaucoma to drive home this you know, macular vulnerability zone. We see it on our deviation plot. We see it very nicely on our ganglion cell. The right eye has me a little bit more puzzled.
Yeah, I agree. The right eye in terms of the ganglion cell actually shows a defect superiorly, but when you look at the deviation map, it's more inferiorly. So it's a little bit kind of, it doesn't really go with what we're seeing. The left eye, I agree, Matt. I think that that defect there is quite focal and quite segmented, and same thing with regards to the GCC as well.
Yeah, and it's a little surprising the way this defect here is not really coming exactly to the nerve.
Yeah.
You know, so I don't have it necessarily a good explanation. It's probably just a little bit of an earlier manifestation than we're seeing in the left eye. And the symmetry, you know, you can go either way on the symmetry for one like this. I don't know, Sanjay, do you have any comments on this one?
Yes, I just want to point out that the, sorry, I need to bring out this loss of nerve fiber layer corresponds to the notching that Ike was referring to earlier. You see that the cup is more notched towards that region, where the nerve fiber layer is lost. Just keep in mind, this is an artifact right here, so you can disregard this. The other thing to notice is that, yes, this is seems to be a nerve fiber layer defect that does correspond to this one right here, but is, as you correctly pointed out, not extending all the way to the nerve. And that is a little surprising, but has been seen in glaucoma before.
Oh, sorry.
You think that's because of the vessel position there, possibly?
It is different, I agree.
Yeah, I don't think it's the vessel position. there seems to be, as you can see right here, there is a loss in the superior portion, right? I mean, sorry, in the inferior portion, which I'm drawing right here.
All right, Matt.
Thank you. So, this is where too, I didn't show a lot of visual fields on purpose for this presentation. I thought I'd just highlight one. Keep in mind that a 24-2 only has 4 points in the main area of the macula. What we're seeing here in this left eye, and this is the one we're more convinced there's glaucoma, here we have a 24-2C. And this has many more points in the macula, particularly in the macular vulnerability zone. And we can see some of those points which would have not been shown in the 24-2, our conventional 24-2 standard, but we are seeing them in the 24-2C. And, of course, we always need to repeat our visual fields, but I think there's a very high likelihood that those are real, and those would have been missed on our standard perimetry. So these are a little bit more rapid fire, I think, to drive home. Everything looks great on this. But sure enough, the more tests we do, the more potential we have for artifacts. This artifact here on the ganglion cell analysis, which again, I don't really like the deviation map anyway. I would have preferred to have the thickness on this aggregate printout. You can see here what's been called a propeller sign. And this is where there's a segmentation issue of the ganglion cell, which is secondary to, maybe I can let our retinal colleagues tell us how they would characterize this, this fovea. Robert, are you able to?
Yeah, so what we see as, a subfoveal, I'd say hypertrophy potentially of the RPE versus also maybe some subfoveal kind of vitelliform-like material that's certainly kind of causing this elevation. You're kind of losing that dip of the fovea as you would have in his right eye. And certainly that could be setting off the segmentation protocols as described.
Okay, thank you. And this is just a case that really shows a lot of these things. I think I'll skip it and just show that this propeller sign or segmentation issue is a reproducible artifact. Unfortunately, it's not one that you can just send them back and have a scan again. This is an inherent problem with their anatomy where we're not going to be able to get perfect ganglion cells. So I've tried to emphasize that I think ganglion cell is now part of the standard of care in glaucoma diagnosis and management for OCTs, but of course it does have its downsides as well, as does our RNFL. And in this case, this is a nice case from John Michelli in our group, and he actually has, I think, 7 of these, where we see an RNFL. We could debate about the red disease that we see in the RNFL, and we see a pretty good visual field. Now, if you just do this, you may not think that there's a huge problem here, but if you do the ganglion cell, you may be more concerned. I don't know if John's still there. Can you invite John in, Ike?
I can. Let me see if John's in. Let me see if he is here. Yep, I'm gonna just promote him to panelist. Let me do that. So John, you should be able to join the group now.
Okay, we see. Oh, here we go.
There you go. There's John.
Hi, thanks for inviting me in. So this is a case where this patient, since we're routinely doing a lot of OCTs on our neuro-ophthalmology patients, we find a few things like this. So this patient has preserved visual function, normal visual acuity, normal visual fields. And when you look at the macular ganglion cell analysis, we see homonymous hemimacular atrophy. So this is telling us that there's a problem with the contralateral retro-chiasmal visual pathways. And this is a study we did with Matt, and we have about 8 of these patients, and we found the differential diagnosis for this is mainly 2 things. One is either previous demyelination of the optic tract, which is the case in here. So this patient probably had a visual field defect when they first had their attack of demyelination. And because in optic neuritis and optic tract lesions from MS, the vision recovers. So what we're seeing here is just a marker of the previous damage that occurred. And so if you see this, this is a case where you may want to either refer to neuro-ophthalmology or have this patient have an MRI to look for signs of MS. The other situation we see this is in traumatic brain injury. So we have a couple patients that were in a serious head injury, and they may or may not have had visual issues, but sometimes this is just a marker for optic tract damage in that context as well.
Yeah, so just to drive home, if the ganglion cell is not an artifact and does not respect the horizontal midline, that is clearly not glaucoma. And if it shows a neural pattern, we need to be very suspicious, even if our visual fields are intact. And this is just the last. I just want to touch on this. This is actually the same patient. I'm going to go right to the deviation map to just show what can happen in the setting of peripapillary atrophy or atypical nerves. So this disc area has been mapped as being completely different in these two different scans. And the issue with this is, and I'll just go to the next slide. The issue with this is that your circular tomogram is going to be in a completely different location for this small nerve, which is really too small to be a nerve, versus this one here. So I just wanted to highlight the T-SNP plot here for the left eye. They're fundamentally different, and that's because the circular tomogram that's been taken is in a completely different location. The good news, so if you just look at the printouts, you have a problem in comparing these two. If you use the actual analysis software, you can see what has happened is that they're using the purple circle from these first two baselines and then using it for this subsequent one as well. And you can see it's quite decentered for what it considered to be the disc area, but at least we can do a comparison of those T-SNP plots over time, which is what I'm showing here. So be very careful. It's not something we focused on in this lecture, but be very careful in your identification of the disc. And this can just be, they can do two scans, one after another, and the machine may put it as, you know, what happened in October, and then 2 seconds later, it could do it for this February one. And of course, we have our faithful, trustworthy ganglion cell analysis, which is not as affected by these types of things.
Matt, very quickly, if Jonathan is still there, someone has asked, how does an injury to the optic tract produce changes in the retina?
So that's a good question. So because in the ganglion cell layer, you have the cell body of the retinal ganglion cell, and then the axon travels all the way through the retinal nerve fiber layer through the optic nerve chiasm, and its first synapse is in the lateral geniculate nucleus. So if you have any damage along that pathway, it'll actually manifest in the retina, and it usually typically takes about 1 or 2 months for that to happen. So if someone has a stroke that involves the optic tract, you'll see pretty quickly a homonymous atrophy in the macular ganglion cell complex. Also, we now know that if you have a stroke in the occipital lobe, you can also see homonymous macular ganglion cell atrophy. That typically takes much longer, up to 1 or 2 years. So it's really because there's one nerve cell that's going a long pathway, and if you damage it in the tract, you'll see the thinning in the retina.
Great, thanks.
Okay, well, thank you to all of our panelists, our retina doctors as well, helping us out to interpret our glaucoma scans. I really appreciate all those who stuck through to the end.
Well, thank you, Matt. That was wonderful, and I want to thank you and Dima. I want to thank our special guest Sanjay Asrani for being here. We didn't give him any prompting. He was sharp as always, and I want to thank Jonathan Missiali, one of our neuro-ophthalmologists at University of Toronto as well, for his input as well. Of course, I got to thank again Rajiv Muni for putting together the retina section with David Saraf as well as Robert Gaziski. So thank you all for being here as well. And we had a lot of people out here. We still have about 600 people actually to the end. So it's an incredible turnout from all over the world, which is great to see everybody. Just a couple of things. We are doing a joint session with Ophthalmo University. I think Jeb has it up on your screen. This is going to be on Tuesday. Our rounds run every Wednesday at 3 o'clock and every Saturday at 12 noon, like today. And next week, we have a couple of cases, anthracycline cases, glaucoma, as well as complex cataract. And I think you're going to enjoy that as always. Keep the suggestions coming. You have the email address on our website that you can go to as well. And Jeb, I don't know if you want to put the website up there. Most of you have already been through it already, but it's at prisminstitute.com/webinars. Again, I want to thank you all, and I want you to please keep safe, stay protected. These are unsettling times, and for many there's a lot of fear, of course, and fear does drive different kinds of behavior. Once we kind of get past that phase, of course, let's try to get together. This is a great opportunity to learn, to share ideas. Even being together, I think, gives us all some strength. And so this will soon be over. I think we'll be able to learn from all the things that we're doing now and probably change a little bit what we're doing in the future. So hang in there. Take care of your families. Take care of yourselves. Stay in touch. There's so many choices in terms of what you can do with your time. I find myself, I'm actually busier than usual with our virtual care for our patients, as well as figuring out what we're going to do after as well. So thank you again. I want to thank all the panelists for being here. Spread the word. A lot of great opportunity to share knowledge. Thank you again for all the preparation you guys have made. Thanks, Jeb, for putting it together. And we'll see you on Tuesday if we're going to be there. If not, Wednesday for the next webinar. Thank you very much.
Thank you for hosting. Thanks.
Thanks so much for putting this together.
Thanks, guys.